Hello, and welcome to the Clinical Liver Diseases video series. CLD is an official digital learning publication of the AASLD. I'm Ahmed, an aspiring hepatologist, graduate of the University of Cincinnati Internal Medicine program, and the author of Advances in the Management of Idiosyncratic Drug-Induced Liver Injury. First, let's define the problem. Idiosyncratic drug-induced liver injury is a leading cause of acute liver failure in the United States, and the most common reason for drug withdrawal from the market. Incidence is reported as 19 per 100,000. Diagnosing DILI is extremely challenging because it is a clinical diagnosis of exclusion. Today, we will discuss a stepwise evaluation in diagnosing DILI and the role of causality assessment, including recent advances. When you identify abnormal liver chemistries and suspect DILI, a 6-part stepwise approach is best to strengthen the diagnosis. The first step is to perform a medication reconciliation. This includes all over-the-counter and herbal and dietary supplements. You need to next cross-reference this medication reconciliation with the livertox.com database. This is a database with the latest information on the manifestations and literature of over 500 medications and herbal and dietary supplements. Third step is to discontinue the suspected culprit drug. The fourth step is to calculate the R factor. The R factor was introduced in 1989, and it helps to determine the biochemical profile of injury: hepatocellular, mixed, or cholestatic. The fifth step is to assess for more common causes of liver injury, such as alcohol, viral, autoimmune, hepatobiliary, ischemic, congestive hepatopathy, or cholestasis of sepsis. And your sixth and final step is to perform causality assessment to determine how likely it is that the suspected drug is the culprit. Causality assessment began in 1992 when the Roussel-Uclaf causality assessment method, the RUCAM, was introduced. Later, in 2009, the Drug-Induced Liver Injury Network created a 5-point expert opinion scale to adjudicate DILI cases with a team of hepatologists. These two methods have been the backbone of causality assessment for the past decades. However, with the advancement in electronic medical records and increased DILI awareness, there became a need to update, and thus the revised electronic causality assessment method, the RECAM, was born in 2022. The RECAM restructures the original 7 RUCAM categories into a 5-domain menu-driven assessment tool. These 5 domains are time to onset, D-challenge, liver tox likelihood score, competing diagnoses, and additional data, if available. RECAM has many improvements over the RUCAM through consolidation of categories, restructured scoring, and a more objective approach. Side-by-side comparison is shown here. A recent study showed the RECAM was superior to the RUCAM in classifying either end of the causality spectrum, highly likely DILI or excluded DILI. It is also shown to be in accordance with the Dillon Experts Opinions Causality Scale. Finally, RECAM is computerized and semi-automated, allowing for more reliable case adjudication and fewer operator errors. What we hope you take away from our paper and this presentation are 2 key points. First, the need to use a stepwise approach to ensure timely diagnosis and hopefully reduce the frequency of adverse outcomes. Secondly, the use of the computerized and simplified RECAM instrument should hopefully improve diagnostic certainty in clinical practice, but further studies are needed. We encourage you to read the full article to better understand the finer details of DILI advances, as well as to learn of some new insights on HLA alleles and etiology-specific treatment of DILI. On behalf of all of us on the CLD team, I hope you found this DILI management review useful. For more information about DILI, please visit us at www.cldlearning.com. Thank you for watching.